1 in 8 women receiving a diagnosis in their lifetime. Nearly all of us know someone that's been impacted by this disease. Some people have higher risk factors, as we know. For so many, a breast cancer diagnosis is completely unexpected. So, where do we turn when we receive a diagnosis? The Walker Breast Program at TMH and the Cancer Center provides the region's most advanced comprehensive care right here in our backyard. The Walker Breast Program focuses on shortening the time that it takes for a patient to go from diagnosis to treatment and brings cancer care specialists together under one roof, meaning patients receive high quality care, multidisciplinary treatment at one location without the need to schedule multiple appointments all over town or even outside Tallahassee. I'm Sally Bradshaw. It is a privilege to be here tonight with these amazing providers at TMH. I am a TMH board member, but more importantly, for purposes of tonight, I'm a breast cancer survivor. It's been 5 years since my diagnosis, and I'm always anxious to have these folks captive, their big brains, and get all this information. And it's very exciting for me as someone affiliated as a volunteer with TMH to know what incredible care we have on the breast cancer front right here at home. So I want to introduce our panelist. Dr. Shelby Blank is with us. Dr. Blank is the medical director of the Walker Breast Program and a breast surgeon at TMH. Dr. Schlermine Everidge is a fellowship-trained breast surgical oncologist at TMH and also trained at MD Anderson, so we were glad to get her back to Tallahassee. Dr. Janine Silberman, who is a medical oncologist and also a psychiatrist at TMH, and that's just such an interesting combination of skills. So we're anxious to talk with you tonight, Dr. Silberman, and of course, last but never least, Dr. Alfredo Paredes is a plastic surgeon at Tallahassee Plastic Surgery Clinic and TMH. Thank you all for joining us this evening and welcome. Some of our viewers have submitted some questions in advance, so I'll be walking you through those as we get into this discussion. If you have additional questions as you go, please hit the Q&A button at the bottom and I will monitor those and try to work them in as we get through the discussion. Let's get started. Where so many breast cancer journeys begin, which is with breast cancer screening and diagnosis. And I'm going to start with Dr. Blank, the director of the Walker Breast Program. What's the importance of routine screening and detecting breast cancer early, especially for younger women who feel healthy? I mean, I know this is beat into us all the time, get your mammogram, but why? Why is that so important?
I cannot overemphasize the importance of early screening, early detection. By the time you often can feel a breast cancer or feel symptoms from a breast cancer, we may be really far down that pathway. And so our real opportunity to impact survival and to impact how much treatment someone may receive is really impacted by having that early diagnosis. And what we believe currently the best option for that is screening imaging, so a screening mammogram. There's often, every few years, new recommendations will come down the pipeline and where people have looked at, can we delay or defer screening to a later age? And we continue to strongly recommend kind of those very classic recommendations that are still maintained by the American College of Surgeons, American College of Radiologists, which is to start for an average risk patient. So this is across the board to start screening imaging at age 40. What is important is to have a real discussion with your physician, with your family physician, with your gynecologist at an earlier age. So even as young as 25, to kind of look at what are your risk factors. For most people, that age 40 timeline is a really sound one. But if you have someone in your family that was diagnosed at a very early age, you have a strong family history, there are some things that can impact those screening recommendations, in which case we don't want to miss that opportunity to screen those folks at a much earlier age.
So, for example, someone like my daughter, because I've had breast cancer, might speak with her doctor about beginning screening earlier.
Exactly. And broadly, we would like to say if someone, a first degree relative, so a sister, a mom, whatever their age of diagnosis, if it's earlier, essentially earlier than 50, you want to start that screening at least 10 years prior to that. So if a patient was diagnosed at age 45, you're going to want to start that screening at least by age 35. So those are certainly things we don't want to wait until you're 40 and say, oh my gosh, I wish I'd known about that, years past.
So what role does self-exams play, and what does a proper self-exam look like? I mean, that's always been something that's confusing, I think, to me and other men and women.
It really is, and it's difficult, and we do not expect people to be experts because people's breast at one time of the month may feel differently than another time or one time during your lifetime. And so we've kind of replaced the idea of self-exam with what we call self-awareness. So essentially know yourself well enough such that if something new, different, or abnormal shows up, that you're cognizant enough that you would notice that. So you don't have to, realize, gosh, every lump and bump, is that something or not? But just kind of know yourself so that if something profoundly abnormal shows up, that you will realize it. So again, if you can do it, if you can do it once a month or every other month, so that months don't go by that you really just don't aren't aware of what's going on. But no one expects, the pressure of diagnosing a breast cancer, by your self palpation alone. So.
Are there other signs and symptoms that we should look out for?
So there can be, in rare cases, breast cancer can manifest as skin changes. That's not typical. Most breast cancers are actually diagnosed by a finding on mammogram. That's, typically, but you can have discharge. So typically, any nipple discharge that has blood in it is considered abnormal and needs to be checked out. Many people have what we would consider physiologic or normal nipple discharge, which is clear, yellow, white, and that's typically not something that is worrisome. But anytime we add blood into that equation, that is something that needs evaluation. Like I said, skin changes, a lump or a mass in the breast or under the arm, those are all things that should be checked out from a breast cancer standpoint.
Got it. Thank you. So, Dr. Everidge, I'm going to shift to you to talk a little bit about what outcomes often look like for patients when breast cancer is detected in an earlier stage versus a later stage.
So early detection is important, not just because, finding something early is fun, but because we actually do see improved overall survival and outcomes in that sense. 10-year overall survival or 10-year recurrence-free survival in a lot of these early stage breast cancers that are commonly diagnosed is in the 90s, in the high 90s. So catching this early allows for a better, prognosis long term. A lot of these patients are living long, healthy lives if we can do something about it early.
And how does that affect treatment planning if you've caught it earlier?
It usually allows for a lot less of a surgery. So typically, and I'm sure we're going to talk about this later on, surgical management is usually the first step in a lot of the breast cancer treatments that we come across. It allows for a lesser surgery. Typically, it can almost, I would say, reduce the risk of needing chemotherapy. And sometimes the cancer biology plays a role in that. But it allows us to have to do less in order to treat this cancer.
Got it. Dr. Silberman, medical oncology, from a medical oncology standpoint, why does early detection matter so much for treatment planning from your perspective?
Yes, ma'am. So it sort of piggybacks on what Dr. Blank and Dr. Everidge were saying, which is early detection saves lives. First and foremost, we have an excellent screening test. So by definition, a good screening test is one that saves lives. The earlier the cancer is detected, the higher the survival rate. So, for example, 5-year survival for stage 1 breast cancer is nearly, Dr. Everidge just said, 98%. I mean, it doesn't get that much better than that. So, and with each stage progression, stage 2, 3, and 4 being metastatic disease, those survival percentages decrease.
So yet another reason, get your mammogram, do your self-exams, notice any changes, something that seems different, get regular exams. And Dr. Paredes, does early diagnosis, early detection change or benefit plastic surgery in some way?
Definitely. So earlier diagnoses are the indication for breast reconstruction. When a patient is diagnosed later stage, we tend not to do reconstruction right away, wanting to be very aggressive with the cancer. Later stage patients are more likely to get chemotherapy, radiation right away. So that might push us to delay our reconstructive part till later, making sure that we've gotten through that. We don't want reconstruction to potentially delay any type of important cancer care. So when you're caught earlier, really what it does is it opens doors for all kinds of reconstructive treatments.
That's great. So every reason again to catch it, stay on top of it. So, but let me say this as a breast cancer patient, and as someone who has to get MRIs regularly and mammograms regularly, it is still anxiety producing. So when I asked Dr. Blank and also Dr. Silberman, given her background in psychiatry, a lot of us put off these mammograms because of fear or discomfort. It's not, super fun. It can be a little unpleasant. And also because we're unfamiliar with screening guidelines, what would you say to someone who isn't getting their mammograms because of those feelings? How do we, convince people to get beyond that? What advice would you give?
So I do think that people, either delay or avoid getting their mammogram for a lot of reasons. And it can be fear of, if you don't know something's there, then, it's not as scary. Fear of discomfort. A lot of people feel like even if they've never had a mammogram, you hear people talk about, that it's uncomfortable, it hurts. So there's a lot of, and even, when you've been through a cancer diagnosis, it's even more scary because, kind of the worst has happened and that part of it is a challenge. I think for every person, there's a different approach. I would say that if you're delaying or deferring a mammogram because of you're worried about the discomfort, we've come a long way with new machines, new ways to pad, new ways to get a better image with less compression, with digital and tomosynthesis. So those are different, ways that we can, the tomosynthesis is another name for the 3D mammogram.
Yeah.
So I think the technology is better, which means there's sometimes not the need to necessarily do as much compression, which means it's a more comfortable test. Again, they've gotten fancier with padding. We have great mammo technologists who understand what it's like and what it feels like, and they really will work with you to make it a pleasant experience. They're absolutely girls at both at Women's Imaging and at TMH Sharon Ewing Walker Center are just lovely. If you're a person who just doesn't image well on mammography, or you have certain other risk factors, MRI can be a good option. And again, a breast MRI is different from MRIs of other body parts. And so almost everyone, it's, again, it's not, these aren't things that you want to sign up for voluntarily as a hobby, but I think you make a pact with yourself that once a year, or once every 6 months, depending on your recommendations. But for most people, once a year, you're going to, set it as a date that you will absolutely remember, whether it's your birthday, your anniversary, something that has a positive connotation so that it has, kind of some happiness associated with it. Some people I know will have a buddy. So they get their best friend or their two best girlfriends and say, hey, we're all going to do this on the same month and we'll go out to lunch afterward or whatever. So I think whatever is going to work for you, but maybe associating a positive experience with it as well. So.
Anything to add to that, Dr. Silberman?
Absolutely, I absolutely agree with Dr. Blank. Bring your friends, make it fun, go somewhere nice after. I think however you can convince yourself that it's a good experience, if it gets you there, then terrific. Success.
And I also look at it as a breast cancer patient, knowing that I want to do it because, again, if my breast cancer to return, they would find it quickly and the treatment options would be much better yet again. And so for me, that's how I kind of look at it.
Absolutely.
So, Dr. Average, back to you. How does the team at TMH work with radiologists for diagnostic screening and throughout treatment? And what role do they play in the Walker Breast program?
The radiologists are actually a key player on the team, and they're often not talked about enough. We're talking about screening and trying to catch this early, and so those are usually our first, the people who would catch things first, right? They're the ones picking up on these mammogram detected breast cancers, making sure to reach out to the PCPs and to the OBGYNs who are ordering these mammograms, that making sure that these biopsies are then done to diagnose the breast cancer. So they are that's how we get our diagnosis to be able to treat these patients. And so I know we don't really talk about them enough, but we definitely work closely, although they're not much talked about. I would say all of us have a really good relationship with a lot of the radiologists in town, specifically the breast radiologists, and they communicate well with us. I mean, when they know a patient of mine is getting another imaging, they'll call me and say, hey, everything looks good. Let your patient know. So, they are a big part of that team.
Dr. Silberman, and I also want to bring in Dr. Paredes on this actually, because I imagine that he deals with this some too. Are there common fears and misconceptions patients have when they first receive a diagnosis that you guys can set straight?
Well, I'll share an anecdote with you. I had a patient, this is probably now some years ago, that came in for a consultation for stage 1 breast cancer. And this is unusual. It's a very sort of, it's one of those experiences you don't forget. She came in and she had called hospice for herself for her stage 1 breast cancer.
Oh my gosh.
And the reason that I point this out, although, that's the only patient I've ever had that happen with. I've had everything between that and sort of a more typical experience. By that, I mean that cancer is not a death. Along the lines of what we said earlier, we have a great screening test which saves lives. Most people are cured. So that is a fear and a misconception. Unfortunately, we do have other types of cancers where that's not the case. Colon cancer, we've got a great screening test, colonoscopy. That is not the case with many others. So, but we are fortunate in this realm, in the breast cancer realm, to say that we were highly, highly successful. So please let that allay your fear and go ahead.
Dr. Paredes, can you add anything to that?
Yeah, I think the most common misconceptions I see come from either well-intentioned family members who come with their own personal story or something they heard from a neighbor, and they tell the new patient about what their neighbor went through. And breast cancer is such an individual, unique diagnosis, treatment, depends a lot on your own past medical history, that it's really difficult to try to cookie cutter paste every patient into one method of treatment. There's so many different ways to treat. Sometimes we give chemo first, sometimes we give it later, sometimes we don't give it at all. It just depends on your cancer. I think the internet, while it's good for information, can lead patients to look up a lot of things before meeting their doctor in an attempt to become well informed. And I think sometimes it leads them down roads of sort of internet falsities that are just out there. So really the recommendation is just, you get your diagnosis. As much as you want to go look things up, wait to speak to your doctor. Try not to preempt the conversation with your physician, just so you can hear that information first, because I think your neighbors and friends on the internet will tend to scare you more than it helps.
That's great advice and a great segue to Dr. Blank to talk about the Walker Breast Program and all the wonderful breast cancer treatment options we have available in Tallahassee. And Dr. Blank, you played a large role in developing the program, and you sort of lead this effort. What specialties are involved when someone gets a breast cancer diagnosis and they come to the Walker Breast Center?
So yeah, with this, I won't date myself to say how long we've been sort of working on this, or when we first kind of started to theorize this. But as Dr. Everidge said, oftentimes when patients are first diagnosed, it's through a radiologist having read an abnormal mammogram or having performed a biopsy, and then that would circle back to the patient's primary doctor or gynecologist, who would then send a referral somewhere. And sometimes that referral would be sent to a medical oncologist. Sometimes it would be sent to a surgeon. Sometimes additional imaging would be recommended. And what we were realizing is that patients sort of got into this kind of morass of needing all of these appointments and all of these follow-ups and additional imaging and additional biopsies. at what it was a very stressful period with a new diagnosis, and they really just didn't know where to turn. And so some people felt like, well, maybe I need to leave town and go to an academic center or a big name cancer center. Some people said, I don't even know what to do, and got a little bit of paralysis, which leads to a delay in treatment. And even the people that were in the throes, it took a long time, and it took a lot of emotional and physical energy to go through that process. And so our goal was to take all of the people, and this is the radiologist who look at all of the imaging, the pathologist who look at the slides of the tissue and tell us if this is a cancer, and if so, what type of cancer, what are the subtypes, which has become increasingly important in recommending treatment and order of treatment and type of treatment. Surgeons, medical oncologists, radiation oncologists, plastic surgeons, our clinical geneticists who sort of tell us, hey, does this patient have an inborn genetic mutation that makes them at more risk for this or other cancers? As well as our nurse navigator. So there's a whole team, social workers, et cetera, that can kind of help facilitate this process from beginning through to what we call survivorship, which basically means we've moved through the diagnosis, through the treatment, and now we're intent on keeping that person healthy for the rest of their life. So our goal was to really bring this kind of all into one more seamless process, where that diagnosis, their doctor or the radiologist could send one referral and essentially kind of create a cascade that the patient didn't have to facilitate, but that we would facilitate. We would bring the patient in, see them, discuss them at our tumor board, kind of bringing that into their initial clinic visit, so that in real time we were talking to them, giving them a plan, hooking them up with any additional adjuvant, imaging, and getting them in touch with the people that they needed to see to go through the steps of treatment. So, and I think we're not perfect, but I think we've made a huge dent into achieving that goal. So,
Well, it strikes me, you're the A team, right? And you guys talk all the time, you respect each other, you work together, you're friends. I mean, that's something about community care that I think adds to the experience at the Walker Breast Center. We were talking about this a little bit before we started. And Dr. Everidge, how important has it been to you to come back to Tallahassee and practice in an environment where you can just pick up the phone and call Dr. Blank or Dr. Paredes or Dr. Silverman and immediately get a response on a patient's information or scan or testing?
I will tell you, that's probably the best part of working here. Coming from a really large institution where, finding someone wasn't always easy and having to wait for communication, that's been night and day difference between that and what I have here at TMH. Being able to kind of talk to a patient and say, hey, let me get your medical oncologist on the phone and we can just chit chat about this, and I'll give you a call. And I mean, I've gotten responses so fast to a question I may have, like to Dr. Silverman or the other medical oncologist, to where by the time I've called the patient, they have just left the lobby and, they're on their way home from their appointment. And I was like, hey, just to follow up on something, I spoke to your medical oncologist, or I spoke to Dr. Paredes about, I saw you, it's been a couple months since you last saw him, and I noticed this thing. Let me talk to him about that. Or, your drain seems to be putting out a little bit much. Let me reach out to him. And it's really probably the best part of working in this environment is the immediate communication for our patient cares that we are able to have.
And it's so important because so much of the challenge for patients is waiting for information, being called back, additional screening, and to be connected on a very personal level with the providers is just something that's really appreciated. So we're all incredibly grateful for that. Dr. Everidge, I mentioned, completed a fellowship at MD Anderson Cancer Center. And you came back because you are the region's first fellowship trained breast surgical oncologist that we've had. And so how much do you think your training at MD Anderson has been a benefit to you and to patients here?
I will say part of me going away and coming back was realizing, what, we're doing the right thing. It's one thing when this is all you take a step back, you go and explore other places and you realize, what we were doing here at TMH is the right treatment. We're doing the right things. Part of going and doing a fellowship is learning the why behind what we're doing. And so, you know, it adds a little bit more of an academic feel to that. You can justify things a little bit better. There are certain nuances that exist and not necessarily for every patient. But I mean, really what that fellowship did was reinforce what we're doing here already and add a little bit of an academic touch to that.
That's nice. Well, we're grateful that you came back. I know the team is glad to have you here. Dr. Silberman, aside from the obvious regions, such as providing high quality cancer care, why is it important for Tallahassee and the region in general to have a program like the Walker Breast Center?
Well, when you have a cancer diagnosis, the last thing you want to be doing is traveling, right? You want to be able to sleep in your own bed, be with your family, bring a friend if you want to your appointments. And so the fact that we can offer that here close to home, I think is critically important. But we have all the teams we need here. You know, we've got the multidisciplinary teams. So unlike other cancers, breast cancer involves there are a lot of cooks in the kitchen. So you might have had your mammogram ordered by your primary care physician, who then puts in a referral for a biopsy to a radiologist. And then you get a referral to a general surgeon. And then the general surgeon refers you to the plastic surgeon. And then you go in and see the medical oncologist. And hopefully this is happening in an expedited fashion, which is the goal of the breast cancer program that we have, and why we have that clinic and conference every week. So for all those reasons, to expedite your workup, to have a multidisciplinary care with ease of communication, clinical trials right here at home, they're all, I think, wonderful addition to an already amazing program.
Thank you. Dr. Blank, I want to talk specifically about the surgical process, and everybody feel free to jump in and weigh in on this. Certainly Dr. Paredes is the plastic surgeon of the group, but can you talk about what the surgical process looks like for patients when they begin their breast cancer treatment? So from the first time they meet with you until their surgery and even their follow-ups, what's actually happening for this patient?
Sure. You know, there are a few patients that for whom surgery will not be the first step in their treatment. So there's a kind of a small subset of patients, and much of that has to do with the type of cancer that they have. A little bit of it has to do with stage, but mostly it's type of subset of cancers that will receive chemotherapy first. And so for them, surgery is a little bit delayed, but the vast majority of folks, we're talking about surgery as their first step of treatment. And that kind of falls into one of two categories. And it used to be very straightforward. And now there are a whole lot of options, and Dr. Paredes can kind of, you know, chime in. You know, once upon a time, it was just mastectomy. And then for now a healthy length of time, we've had the options of what we call breast conserving therapy or lumpectomy, which is just removing the cancer, but keeping the breast intact. That's often accompanied by other modalities of treatment, such as external beam radiation, intraoperative radiation therapy. There's all sorts of options. But basically, lumpectomy or mastectomy are kind of our options. But within that, there's the opportunity for what we call oncoplastic reduction, which essentially is coupling a lumpectomy and allowing us to take a much larger area of tissue, a much larger tumor, and coupling that with kind of a reconstructive lift reduction. And so this is, you know, I won't say new under the sun, but it's something that didn't exist when lumpectomy first became a treatment option. And so, you know, at that time, if you had a 5-centimeter tumor, you know, or larger, you weren't really a candidate for a lumpectomy. It was kind of a relative contraindication, and those sorts of recommendations have gone by the wayside. So I would say the vast majority of patients are great candidates for breast conserving therapy, even if they may have a slightly larger tumor. On the mastectomy side of things, we have a lot of opportunity to create all different sorts of reconstruction depending on patient preference. So we think about reconstruction using implant-based reconstruction. We also have the opportunity to use the patient's own tissue with flap-based reconstruction. And then a lot of patients are choosing what we call the aesthetic flat closure. There's kind of been a recent what we call the go flat movement, where patients aren't really interested in breast reconstruction as we think of it, but really want sort of a nice cosmetic flat closure. And so there's a lot of, there's now so many different options, and our local plastic surgeons are super supportive and really do a great job. So we're very lucky on that front. But that's kind of part of that whole discussion about, which surgical options you're interested in. Surgery, for the most part, for all of those options, are often an outpatient procedure. So patients are able to have their procedure and go home the same day. At most, they may spend a night in the hospital, but it's a much easier, quicker recovery. There are some things that we've been able to add to make the postoperative discomfort a lot better. So really, it's not from a recovery and a pain standpoint, it's typically very well tolerated. With mastectomy and some of the reconstructive options, patients may have drains after surgery, and they're typically going to see both their breast surgeon as well as their plastic surgeon, if they have one, quite frequently right after surgery. As they kind of recover, then they move into the next phase of treatment, and then we bring in the radiation doctors, the medical oncologists, and those sort of other members of the team once they've kind of healed from that surgical process. So.
Well, that leads to a question for Dr. Paredes, which is not everyone decides to have reconstructive surgery or to have reconstructive surgery right away, but it doesn't matter because you're constantly collaborating and speaking with these other physicians. Why is that collaboration so important? And, frankly, some people will have a question, do they have better outcomes if they have reconstruction right away, or if they delay, or does it matter?
That's a more complex question than it sounds. So
Sorry,
first,
I added that on for you.
Yeah, so first, a patient will see a general surgeon, and like we talked about earlier, earlier diagnosis means you're more of a candidate for having an immediate reconstruction. If you have a later diagnosis, we'll tend to delay the reconstruction until we get through all our cancer treatments, make sure we get past everything, and do it in a delayed fashion. Good news is insurance does cover both immediate and delayed reconstruction, so it doesn't really matter in terms of timing. Results sometimes are better when it's immediate because we can preserve the breast skin envelope more easily when we combine it with the general surgeon's mastectomy. But that's not always the case, and it depends on the type of reconstruction you're having. But essentially, it comes down to the general surgeon seeing the patient first, determining if we have a method or way of assisting this patient. Then they'll make a referral to us, and we're usually seeing them within a day. And then we come up with a game plan together. Sometimes I will call the general surgeon and say, hey, in this particular case, we should do this, or I'd recommend this. I've had, just like has been discussed tonight, conversations where I'll tell the patient, if you give me a minute, I'll go call your general surgeon, and inevitably, within 2 minutes, I've got my answer. I'll come right back into the room and say, hey, we spoke and we think we should offer this. We are so more involved than when I train, meaning we are now more involved on just lumpectomies, for example, or someone who wants to go flat. We can be involved with what's called a Goldilocks procedure or a dermal flap. These are things that maybe weren't thought of 20 years ago. Today has become very common. So we're now involved, whether you're having just a mastectomy, a lumpectomy, or you want reconstruction of the mound after mastectomy. So the indications to see a plastic surgeon are more common. And I do like it when a patient is offered the opportunity to see us after they've seen the general surgeon, even if they're not sure they want reconstruction, because at least it gives us an opportunity to explain what her options are. And then, of course, she might decide, you know what, thanks for the conversation, but I don't think I want a mound reconstruction. Well, I think that decision is easier to make when you've heard all the options put before you. Some patients tell me, sounds great, I'd like to have a mound, but this is emotionally overwhelming. And can I just do just the mastectomy and come back later to you? I said, absolutely. And in fact, most of the options we discuss are still options later, but at least a patient has an idea of what they could go through. It allows them time to research, talk to other patients. So the good news with our part is it's not the essential part. Really, we have to get rid of the cancer. That's the goal here. And I need to make sure that what I'm going to do is not going to delay a patient's care. because things can have, surgery can have complications. So we have to weigh the risks to the benefit ratio and just figure out, is what I'm going to do going to be good for cancer care? And what if I have a problem? Is that going to delay things? And these are the conversations we have with our patients. Our consults are long. They're usually an hour long. And it can be a bit overwhelming because now you've met the general surgeon, you've talked to a radiologist, you might have talked to a medical oncologist, and now you're finally seeing me, and I'm going to try to put it all together. But it's important to hear all this before you make your decision going forward. So we like it when we see patients ahead of time, just so they can make the best decision for themselves.
Have more information is always better in making these decisions. Dr. Silberman, back to you. What kind of drug treatments does TMH provide for patients with breast cancer? And beyond chemotherapy and immunotherapy, which I think you'll probably talk about, are there other treatments that potentially could be deployed?
Sure. Well, first I want to mention their chemotherapy is not all intravenous. We actually give quite a lot of oral chemotherapy, both to patients who have metastatic disease, so stage 4 disease, where it's left the breast and the region under the arm and has gone elsewhere to a distant site like the bone, the lung, the liver. We do that quite frequently. We also give oral chemotherapy to patients who are high risk for recurrences after they've had chemotherapy up front, something that we call neoadjuvant chemotherapy, followed by surgery. And if they have much cancer left at the time of surgery, we're giving oral chemotherapy drugs. One modality that was missing from that list is endocrine therapy. So if you have a hormone receptor positive breast cancer, you are probably going to be offered endocrine therapy, which is an anti-estrogen pill. And depending upon your menopausal status, it might be either tamoxifen, which has been around since the 60s, or an aromatase inhibitor for postmenopausal women. We often offer something that's called ovarian follicle suppression, which is an injection. It's given to women who are premenopausal and are high risk for breast cancer recurrence. Sometimes they will have their ovaries removed as an alternative to a pharmacologic ovarian suppression. And then one thing that was missing from the list that you mentioned is radiation. So we do not have a radiation oncologist on our panel tonight, but I can say that we offer that here at the Cancer Center, and it's an integral part of our services. So women that have lumpectomy or breast conserving therapy are often offered radiation after their surgery. Patients that have lymph nodes that are positive are typically offered radiation. And there are some other circumstances, like if you have what's called positive margins, meaning that there are cancer cells right around the edge of the surgical resection. You might also be, in particular, if it's not feasible to resect it and get clear margins, you might be offered radiation. So there are a lot of roles in which radiation would be part of your therapy plan.
And I'm glad you brought up the radiation oncologist, because typically I was just going to say, typically we would have one tonight, but unfortunately we could not have one with us. Go ahead, Dr. Silberman.
And we also have research here, which is hugely important. So we offer all sorts of trials. We have drug trials, clinical drug trials for a variety of different cancer types, including breast cancer. We also have survivorship trials. So looking at outcomes in patients who have survived, beyond whatever time frame is specified by the trial, might be 5 years, might be longer, looking at things like cognitive function after treatment. So a lot of patients will report that they have, what's called chemo brain or cognitive dysfunction. We have a mindfulness trial looking at that for survivors of breast cancer. And we have registry trials as well. So keeping an important part of a cancer registry is keeping track of the number of cancers, the type of cancers. And in our particular trial, it's not didn't originate from our site, but we participate. I want to say it's University of Nebraska. They do keep biospecimens, which are very important for furthering research in the area of breast cancer.
I want to stick with you for just a minute, Dr. Silberman, if we can, given your psychiatry background, and talk a little bit about the role mental health plays in a breast cancer diagnosis. What resources does the Walker Breast Center have for women on that front or breast cancer patients?
Right. So we screen our patients for anxiety, depression, other mental health issues when they come in. For some people, it might just be that they're anxious because they have a new cancer diagnosis, and it's a well-adjusted sort of behavior that's appropriate, and it's not functionally impairing for them. But for other people, it might last longer or interfere with their ability to function. So in that case, they might be referred to one of our licensed clinical social workers, or LCSWs. We do provide short-term psychotherapy, supportive psychotherapy. For patients that might need longer treatment, we would refer them out into the community. I manage the psychopharmacology for my patients if they don't already have a psychiatrist. And I'm happy to do that because it minimizes the number of patient visits that they have. And many of them are already inundated just with a breast cancer diagnosis. They've got all these visits to go to. We are happy to provide all those things. We also have support groups. We have breast cancer patient navigators who understand the illness, understand the resources available, and can guide patients through their treatment.
That's a great point. And I forgot to ask Dr. Blank this, and I meant to ask her about a patient navigator. What's the role of a patient navigator? If I'm a new breast cancer patient, when do I meet a patient navigator, and how do they help me as a breast cancer patient?
So often the breast cancer navigator may be the first person in our whole system that you actually talk to, because we try to have that navigator interaction really kind of start the ball rolling, so to speak. So when a patient has a new diagnosis, we get a referral, and that triggers us not only to set the patient up for an appointment, but it typically also triggers a call from our patient navigator, from our breast cancer navigator, so that they can early on introduce themselves, make sure that that patient has a name, a contact person, and a face to go with it, so that they know they always have someone to call. And that can also identify early on any barriers that the patient may have to getting care. It sounds kind of logistically simple, but some patients work 2 jobs and they really can't take off work, or it's very difficult for them to take off work to even come to their first appointment. So having someone who can help them literally navigate those waters and help them with some of the logistical barriers that folks may have, whether it's transportation, financial, emotional, what have you. So they really are involved from the get-go, and then they will follow the patient through their whole treatment, and really also be part of their survivorship after their treatment has concluded, and we shift into surveillance mode.
That's very helpful to have somebody who can sort of hold your hand through the process and make sure you're connected with information and with providers. Now I'm going to ask Dr. Paredes, and I want Dr. Everidge to weigh in about the use of nicotine, the impact nicotine can have as a risk factor. And as much as I hate to ask it, but I'm going to ask it because I'm hoping the answer has changed from last year. I want you to talk about the use of alcohol in breast cancer and cancer. So let's start with Dr. Paredes.
The usual conversation I have with nicotine in patients is we are here talking about curing cancer. So number one, we can't use a chemical that is known to cause a variety of cancers. So it doesn't make sense to cure your breast cancer while we cause kidney, bladder, lung, and lots of different cancers. So number one, we've got to get off nicotine because it causes cancer. Number two, it has immediate effects on the surgery you're about to have, particularly on a mastectomy. When we do a mastectomy, I tell patients it's like we're carving out a pumpkin, taking everything out on the inside, but we're leaving the walls of the pumpkin behind. That's the skin. That skin requires blood supply to survive the procedure. If it doesn't get enough blood supply, the skin can die. So one of the worst complications you can see in a mastectomy while we're treating your cancer is that the skin could potentially not survive the surgery. This would mean now there's an open wound on the chest, and for someone who now needs chemotherapy or radiation, we would have to delay the care that's subsequent to the surgery. So it's actually vitally important that we get through the surgery well, really without complications, because we got to go on to step 2 and step 3 if we need chemotherapy and radiation. So we always feel that pressure that what we're doing to patients has to heal well. Nicotine is probably the single biggest impediment to good healing. It causes several negative effects on the body. The first is it makes your blood vessels shrink in size significantly. Those blood vessels carry oxygen. So if they're shrunk in size, we're carrying less oxygen to the tissues. If the tissue doesn't get oxygen, the tissue dies. So number one, we can see mastectomy complications from the skin. Number two, at a conservative estimate, nicotine raises your risk of infection 4 to 8 times. So that means you are either quadruple or 8 times multiple more likely to have an infection than someone who doesn't have nicotine in their system. So this is where we get into with patients. The moment you're diagnosed with that cancer by radiology, you really need to stop your nicotine immediately. You should have stopped it sooner, but at this point, if you're a family member and you have a friend or family member who's been diagnosed, they've got to stop their nicotine, because every day, every week that goes by nicotine free increases your likelihood of good healing when your mastectomy comes around. And how you get that nicotine in your body really doesn't matter. So it doesn't matter if you smoke it, if you vape it, if you chew it, if you use a Zyn pouch in your cheeks and gum, if you have a nicotine patch on your skin. It doesn't matter how we get nicotine into the body. So I have a lot of patients who say, well, I started my nicotine patch the moment I was diagnosed. So, well, you're just getting nicotine through the skin instead of inhaling it, but it's still nicotine in your body. So really what we need you to do is quit immediately so that you can have a healthier outcome in terms of your surgery.
So it's non-negotiable.
It is a
Pretty much.
non-negotiable.
It is a
Yeah. Now,
non-negotiable.
obviously, we're still going to treat people who it's an addictive chemical, right? So it's not so simple. I'm making it sound simple to say, well, you should stop your 1 pack per day smoking for 40 years. It's not quite so simple. But I will tell you that in my experience in plastic surgery, when patients hear they can't have plastic surgery if their nicotine's in their system, it is an amazing motivator to quit immediately. So we get lots of patients to quit because they want what's best for their body and they want to heal well. And obviously the scare from cancer alone makes you look at it differently. But the message to get out to patients is we don't want to be using a chemical that causes cancer, nor a chemical that causes poor wound healing.
Thank you.
And to be
Doc-
clear,
I do want
yeah,
to, oh, sorry.
Go
No,
ahead, Dr.
I wanted to clarify just for a second. So nicotine itself is very addictive, and it does that wound healing component cannot be stressed enough. But mostly the carcinogenic aspects of smoking and cigarettes are the other chemicals that are put into the cigarettes. So when we talk about cancer causing, you might get on the internet and maybe the nicotine itself isn't the cancer causing agent, but everything else that comes with smoking, the dips, the packs, all those things are definitely carcinogenic, meaning cancer causing. And so any way that you're putting nicotine in your body likely comes with all of that stuff anyway. So always a good reason to quit. But I mean, Dr. Paredes, any surgeon cannot stress enough the impact that nicotine has on wound healing. It shrinks those vessels. And I mean, I have a patient now that I asked, hey, go ahead and try to quit, which is a big ask of me. And I do understand that this is part of kind of your everyday life. And now cancer has impacted that even. But the amount of wound healing issues that we see is actually pretty remarkable with nicotine use.
That's interesting. Dr. Blank, did you have something to add?
I just wanted to stress, even if you are an active smoker, you are going to get your cancer taken care of. It just may impact how your surgery heals, and your reconstruction. You will still be a candidate for reconstruction in a delayed fashion once you've had an opportunity to stop smoking, recover from your cancer. So it doesn't take it off the table. It just takes it off the table in an immediate fashion and while you're still actively smoking. But I don't want people to think, gosh, well, I can't get my cancer taken care of because I'm still smoking. You absolutely can have surgery. There's going to be some risk involved in it. So the sooner you can, impact that positively by stopping smoking, the better.
Yeah, and I would add that we still want to see the patients, even if they are actively smoking, because as Dr. Blank said, we still need to have that conversation about reconstruction. Yes, it might mean that we might delay your surgery, but you still need to hear all the information about whether you do or don't want reconstruction, what methods are we going to choose. We might, in some cases, alter the way we do the mastectomy, planning for a reconstruction in the future. So 100%, we're still going to see you and treat you your cancer, even if you're a smoker, you're just coming in at a higher risk of having complications.
Got it. And I am going to get back to this alcohol question because there's so much that's been in the news lately about even one drink, you should not have anything. And so I want to talk about that as a component of your process being treated as a cancer patient or just trying to stay healthy. Does anybody want to tackle that one? What we know about that, alcohol and breast cancer? Dr.
You know,
Everidge?
yeah, so I'll tackle this in my limited kind of research, and that may be covering my ears. But you know, alcohol, we always preach kind of everything in moderation is usually a good thing. The more information that we get, more validated science that says, hey, maybe alcohol is playing a bigger factor in cancer development, I think we should listen to that. Yes, I mean, technically it's a poison that we're putting into our body. And so limiting is ideal. But if that research comes out that is strongly validated that, hey, we have linked this to significant amount of cancer diagnoses, then maybe that's something we look at. And that's how science works, right? We find more information, we learn from that, we incorporate that into how we treat things and how we manage things. And so, you know, something maybe I need to listen to as well, but just more information with that. Alcohol abuse for sure increases risk of developing breast cancer because it actually impacts the amount of estrogen in someone's body that can then increase your risk for developing breast cancer. So definitely overuse of anything can cause cancer, but definitely there is links showing that excess alcohol use can increase your risk of developing
more
breast
and more information we need to at least pay attention to. So I want to get to the fun part of this, survivorship, because that's what this team is about. Getting your life back, moving you beyond the anxiety and the surgeries and the medication and the radiation and everything that comes with this, which I'm so grateful we have to offer because it provides such a better outcome. But I want to talk to Dr. Silberman about recovery, survivorship beyond. What does survivorship look like, Dr. Silberman, from a medical perspective? So at what point do you consider someone in remission or cancer-free for breast cancer?
So I don't often use the word remission. We use that for hematologic malignancies like leukemia. In breast cancer, more commonly we'll say cancer-free. Many people are cancer-free by the time I see them for the consultation. So if they had an early stage breast cancer and they've had surgery and they're coming to me, let's say for endocrine therapy for an anti-estrogen medication, or perhaps even for chemotherapy. Let's say they're high risk enough that chemotherapy is warranted after surgery. If I were to do a CT scan or a PET CT scan, I'm probably not going to find anything if they have stage 1 or stage 2 breast cancer. So in that sense, you could say they're cancer free, but they're high risk for recurrence, which is why we're giving them these extra treatments. One does not replace the other. So I often get this question, well, people will bargain. So if I do this, can I just skip radiation and the pills? I don't want the pills. But the answer is they work together, and we know that they work when they're given sequentially. We're able to minimize side effects, and it works. So that's the reason for it. Most people that are going to recur will recur within that first 5-year period. And our follow-up schedule reflects that. So the NCCN guidelines, National Comprehensive Cancer Network, which puts out guidelines for oncology, recommends now that we see our patients that we're treating for cure every 3 to 6 months for 5 years and then once a year. It used to be every 6 months. I think now they're recognizing that not all cancer is the same. So we've got triple negative breast cancers, and we have HER2 positive breast cancers, and they might be at a slightly increased risk for recurrence in that period of time. And as well, they might have gotten more aggressive therapy and need more frequent follow-up in that period. So now we have this guideline of 3 to 6 months for the first 5 years, once a year after that. I often follow my patients indefinitely because there are late recurrences, in particular for hormone receptor HER2 negative breast cancers. So I almost follow along like a primary care physician. And as well, there are quite a few toxicities or side effects of treatment that I need to follow. So somebody might get osteopenia or osteoporosis from the aromatase inhibitor that I'm giving them. There may be issues related to radiation in the long term. So oftentimes we will follow our patients for a considerable period of time. I do make a lot of lifestyle recommendations, and my patients will attest to this. I'm very strict. I've got an exercise program for them that involves cardio. If they can tolerate it, more vigorous exercise where you get your heart rate up and break a sweat. If you can only do moderate exercise, then, so be it. And the amount of time per week might be a little bit higher. And then I have many patients that can't really do much exercise at all. So we'll improvise, whatever you can do, we will work with you. Eating healthy. I recommend a farm to table diet. If it's been sitting in your pantry for 5 years and it's in a package that you have to open, it probably has a lot of preservatives in it. So it's not great for you. Mediterranean diet is a great one. Stress reduction, super important part of this. Minimizing alcohol intake, all these things we talk about at great length. And we may not talk about it up front as much because we're dealing with, chemotherapy or anti-estrogen medications and other things. I want to make sure that they have a bird's eye view of what they're getting themselves into and potential side effects and, things like that. However, later on, we do get into more of the lifestyle modifiable risk factors and the importance of that.
Great, thank you. We've got about 5 minutes left, and I want to remind anybody who's joining us, you can go into the Q&A at the bottom of your screen. Please post any questions we haven't covered because I want to get everybody, I want to get your questions answered. I know we've covered a lot of material tonight, but we're happy to pull up some additional questions. To follow up on what Dr. Silberman said and following her patients, Dr. Paredes, how often does someone who's had surgery with you continue to see you for follow-up?
So I kid around with them that in the first year, they're going to see me more than they've seen their primary care doctor in 20 years. We see them quite frequently, sometimes weekly, because there's a lot of stages to breast reconstruction. So one of the misconceptions that you just have your mastectomy reconstruction, wake up and it's all done. It's really about a year-long process with 3 or 4 surgeries baked into that year, each surgery getting a little bit easier. So there are a lot of frequent visits, follow-ups in our office. After the first to second year, it'll slow down, and it really depends on the type of reconstruction they've had. They will continue seeing their general surgeon yearly or at least twice a year. They'll see their oncologist, and we will take a slightly more backseat approach, but it's not uncommon for patients to come back and want a little touch-up, a revision, a tweak, and we're able to do that, and insurance actually still keeps paying on for that. So we're able to see patients for minor tweaks of their reconstruction going forward. We then, if they have implants, we'll recommend a scan like an MRI or ultrasound of their implant at around the 5th year, and then every 2 to 3 years thereafter. That's the current FDA protocol. Most patients with if you've had a mastectomy, you're not getting a mammogram there anymore. So they'll continue their self-exams with their primary doctor, their oncologist, surgical oncologist. They'll stop seeing us so frequently after that 2nd year and come to see us more as needed. But we welcome all our patients to come back and see us as needed.
I want to close with Dr. Blank and Dr. Everidge. I'm going to start with Dr. Everidge and then come to Dr. Blank. There have been so many medical and technological advances in breast cancer, and I love that Dr. Silberman basically talks about cure, because this is not your grandmother's breast cancer anymore. We're in a brave new world where remarkable things are happening, and you have a team of providers at the Walker Breast Center, and their job is to cure you. We're going to end breast cancer. So starting with Dr. Everidge and then going to Dr. Blank, can you talk about the general prognosis of the disease and how it looks now compared to the past?
And I think I'm just going to bring this full circle where it goes back to screening, but because we're able to screen and catch you so early, like Dr. Silverman said earlier as well, prognosis is dependent on stage. The earlier stage we catch you, which is really dependent on the size and how early we catch it, the better your prognosis is. High 90% of survival with these breast cancers. So, I think people, I'll tell my patients during that first consultation, this is going to be a tough year, but then For a lot of these patients, after that first year, you kind of just start living your life and you're like, wow, I had breast cancer,
Mhm.
you know?
That's a nice way to look at it. It's true. I need to use that. I had breast cancer.
Yeah.
I used to have breast cancer.
Yeah.
Dr. Blank, land the plane for us at 6:59. What do you have to add on that front? It's all positive, I know.
No, it is. I mean, I do think exactly as you said, 25 years ago, we didn't know what we didn't know. And now I think every year we're chipping away at figuring out why breast cancers behave the way that they do and being able to intervene on that. And at the same time, making that intervention more tolerable. So, even people that need kind of the full Monty treatment where they're going to need the most aggressive chemotherapy. There are, we have now cold cap therapy that can minimize hair loss and keep your hair throughout chemo. Cold gloves and socks that minimize that neuropathy that is such a bad toxic side effect of chemotherapy. Hugely important immunotherapy as well as endocrine therapy, which we were talking about earlier, has is really, really impactful. And you sort of think about, well, it's just this little pill you take every day for 5 years, but the impact that it makes on recurrence and the way that has really changed the face of breast cancer, and figuring out which breast cancers need one or the other treatment. So I think that's really the most kind of exciting frontier in breast cancer, is our ability, where in the past we were kind of scratching our head about, why did this person die from their breast cancer when they shouldn't have, or we didn't think they should have. And now we have a lot more explanation and prognostic material so that we can, give patients the treatment that they need to ensure that they have a good outcome.
So important. I am so grateful to each of you. It is always a joy to be with you during Breast Cancer Awareness Month, and I'm grateful to our viewers that joined us tonight. Thank you for your time today. I hope this was helpful to you. I think there will be a recording of it if you need to rewatch it or take notes or get additional information. If you are interested in learning more about breast cancer and the incredible care that these providers offer at the TMH Walker Breast Center, you can certainly do that by visiting tmh.org/go-pink. And you can also learn more specifically about breast cancer treatment at TMH by visiting tmh.org/breast cancer. And lastly, yet again, don't forget one of the biggest weapons that we have against breast cancer, our annual mammogram. And you can request your annual mammogram appointment online at TMH's Sharon Ewing Walker Mammography Clinic. Visit tmh.org/mammogram. So thank you all. Thank our panelists. Thank our viewers. We hope you have a great rest of your evening. Good to see everybody.